Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Astro APM experts for Ukraine. Help Ukraine Group, Astro International Committee, APM Clinical Education Subcommittee, Rise Contra Cancer with Sweet Care support. We are all excited to present the 7th lecture in the course, and the topic is prostate SBRT. We have a team of amazing speakers today. Dr. Mack Roach, that you already know, and he gave an excellent lecture in the previous course, Case Review for Ukraine. And Dr. Martina Descovich. They are both from University of California, San Francisco. So let me introduce them. Dr. Mack Roach is a professor, radiation oncology department at UCSF, who had a major impact on the field of radiation oncology. His body of work extends over more than 30 years, and it's been accentuated by a large number of firsts and challenges to dogma. He asks very good questions. He asks why, and as he mentioned before the beginning of this lecture, he actually ran the trial, very large, one of the largest phase 3 randomized trials. And it took him 18 years to complete the work. So he has a lot of patience. So that's quite incredible. Dr. Roach was a pioneer in prostate cancer research. He developed the first equation to predict lymph node and seminal vesicle involvement, so-called Roach formula. You're familiar with it. It was incorporated into RTOG 9406 and 9413. Later was validated using PSMA PAT. He led the first major trial using PSA as a metric of outcome and helped define Phoenix definition of treatment failure, still the global standard today. He contributed to setting margins, fields, and dose constraints in 3D conformal radiotherapy, guided early IMRT standards, and advanced GRT with fiducial markers. His work with imaging modalities, urethrograms, MRI, and sentinel lymph node imaging shaped precision targeting in radiotherapy. He also demonstrated the feasibility of dose escalation to dominant intraprostatic lesions with IMRT, a concept validated 30 years later in the FLAME trial. He predicted a predictive survival model based on phase 3 prostate trials, showed the prognostic role of PSA, and led multiple landmark phase 3 trials, including RTOG 9413 and 0924, making him the investigator with the largest number of men accrued onto phase 3 prostate radiotherapy studies. He has more than 300 publications, book chapters, editorials. His scholarship has directly shaped clinical practice, guideline development, and national protocols. Dr. Roach has numerous accolades for his amazing work, and last year at Astro, he received the gold medal. So we congratulate him on this. And he also gave a really amazing lecture last year in our case review with Astro experts for Ukraine. So we thank Dr. Roach for all his support for Ukrainian community. And we are looking forward to your lecture. And our second speaker is Dr. Martina Descovich. She's also a professor at UCSF. And she's certified by ABR. She's a medical physicist. She received her PhD in nuclear physics from University of Liverpool, UK, where she developed gamma ray tracking detectors to study the behavior of radioactive nuclei. She specializes in the physics of SRS and SBRT, and she has been the lead physicist of the robotic radiosurgery program since the installation of CyberKnife at UCSF. Her current research is focused on robotic SBRT with emphasis on motion management and target tracking. Thank you so much, both of you, for preparing the lecture today on prostate SBRT. We are looking forward to learning from you, and the podium is yours, Dr. Roach, so I'll stop sharing.
Well, thank you for the invitation. Can you hear me well?
Yeah, we can hear you well.
Okay. I work for Martina. She tells me what to do. You
Excellent.
know, it's a team sport. You know, you can't make it without your physicist. I told my residents, like, you know, you got to just wait till Martina comes back. We got to fix this problem. Anyway, so I thank you for that introduction. I treat a lot of patients with prostate cancer, and we're going to talk about some of the issues related to stereotactic body radiotherapy.
Do you mind swapping displays so we don't see it in presenter mode?
Oh, okay. Let me see. If I swap display, let me see if I can figure out how to do that. Let's see. Swap displays. Just click the
Yeah,
button.
perfect.
There
Yeah,
we go.
yeah.
Okay. So I'm just going to make a very brief comment about external beam radiation versus radical prostatectomy. I don't know what happened there, but the bottom line is that radiation is just as good, if not better. So for those of you that see prostate cancer patients, don't feel like you're compromising the patient's survival if you don't recommend that they have surgery. We've got more information that justifies shortening the courses of treatment. It's cheaper, the biology supports it, and I'm going to give an example of a hypofractionated trial that's matured, RTOG 0415. As you may know, the first two numbers tell you the year the study was open, and the second two numbers tell you what study it was that year. So this is an old study. So moderate hypofractionation is a standard of care. Excuse me, and today I'm going to talk about ultra hypofractionation with even larger sizes. I'm going to mention some of the studies that are sort of landmark studies, including the PACE-B study, which you're all familiar with, SBRT, or ultra hypofractionation versus conventional fractionation. Talk about the PACE-A study, which is looking at quality of life with stereotactic body radiotherapy versus prostatectomy. And talk about SBRT as a new standard of care. Who should be selected for it? What about, should you only include people for whom prostate-only radiation is appropriate, or can you use it as a boost? And the role of androgen deprivation therapy. I won't spend a lot of time on it, but I'll make a couple of points. And then say something about some of the future directions, including the use of MR-Linacs and biomarkers to select patients. So the NCC and the National Comprehensive Cancer Network I'm on the committee, we write guidelines for how patients should be treated for various stages and so forth of prostate cancer. And within those guidelines, stereotactic body radiotherapy, and I don't have the slide in here, is one of the options for patients that are treated. If you look up the specific type of radiation, I'll go into more detail, but for patients with both high risk and intermediate risk, radiation is an excellent option. This is just to fulfill my commitment to talk about surgery versus observation versus radiation, the so-called PROTECT study, which showed that the freedom from disease progression was the same with surgery and radiation and better than observation. And the patients that that were treated with surgery had more problems with incontinence, more problems with erectile dysfunction, and bowel function was very similar between patients treated with surgery and radiation. We think that erectile dysfunction after radiation is related to dose to structures that are critical for obtaining an erection. We focused on the bulb of the penis, which is the proximal portion of the penis, not because it's part of the erectile mechanism, but because it's easy to find. And we think that the structures that are associated with radiation-induced erectile dysfunction are really the nerves and the blood supply and the bodies that form the erected, so-called the corpus cavernosa. They're the ones that are involved. So, but we think that this is an easy landmark. There are some controversies about this, This is from a review article we did some years ago suggesting a dose response in patients who for erectile dysfunction. And my mouse is a little jumpy, but this is another study that we wrote that looked at, we took studies that failed to show a relationship and studies that showed a relationship and showed you, and we created what's called a reliability score. And the reliability score was based on whether or not all the patients were potent, whether the appropriate scale for assessing erectile function was used, whether they had a range of doses, whether they had a single observer or a limited number of observers, and you got points for everything. And so the studies that showed a clear correlation between erectile dysfunction and dose, those positive studies had a lot of points. So they had a lot of real important factors that they included information on. And those studies that did not show a good correlation tended to be deficient in some way. Oh, this is the table I forgot the sequence. This is from the NCCN guidelines from 2024, hypofractionation and ultra hypofractionation, showing the accepted dose per fraction. So in our hands, we for patients that have really low risk factors in terms of not a lot of baseline urinary morbidity, small prostate, and they want to have convenient treatment that can be done in a week, we treat them Monday, Tuesday, Thursday, Friday, or Thursday, Friday, Monday, Tuesday. We use 950 times 4. For patients that have bigger prostates, I'm a little bit more concerned about being so aggressive. 725 times 5 is our standard fractionation. There are some studies, I don't think I'm talking about those in this presentation, maybe I am, looking at weekly versus every other day with this fractionation, showing that weekly versus every other day the results are about. So, and I use that regimen in selected patients that that have some issues, like if they're coming from a great distance, sometimes I just have them come down once a week. And then down here, we talk about for patients that we're treating the pelvis in high-risk patients, we give 950 times 2 followed by pelvic radiation. So we do use it as a boost as well. This was the system. This is one of the many systematic reviews on hypofractionation that show that it's now considered a standard of care. I'm going to skip talking about that in the interest of time. But we always talk about alpha beta ratios, and part of the rationale for why prostate's supposed to have a low alpha beta ratio, and this justifies what we're doing. But I think there's some other factors that people don't talk about, and I just kind of made this up. There's a alpha beta ratio, and then you have factors C, D, E, and F. So these are other things to think about. You have people that say, the alpha beta ratio is 10. Well, for prostate, some people say it's 3, some people say it's 1.5, some people say it's 2. But when we do dosimetry, we're usually down in a very low, we try to be very precise within a percent or 1.5 or 2%, but these are relatively large differences. And so there's room for uncertainty in the alpha beta ratio. And what is this? These alpha beta ratios that were generated were based on studies that only looked at PSA levels. And PSA is not consistently been shown to be a good surrogate for what matters, which is survival. So there's some issues about, is our endpoint valid? But we do know that big fractions work. Whether the model for alpha beta is very accurate or not, it's certainly a useful tool. And it doesn't take into account where the cancer is. It doesn't take into account typically whether there's pelvic lymph node involvement. I mean, there are other factors that are in there. So we have to be cautious because the PSA failure is not necessarily a good correlate. A Gleason score is the single most important predictor of death, but that's not in the alpha beta ratios. It's more important than PSA. T stage, whether the patient has T3 disease that is seminal vesicle involvement, is also more important than PSA. But and age actually as a prognostic factor may be equal to or more important than PSA, but PSA is the most predictive factor for biochemical failure. So we know that there's some potential issues there. So we have these systematic reviews. We have data from HDR, which is how we created our dose constraints, and our fractionation was based on our experience with high dose rate brachytherapy. So it's logical to, the alpha beta ratio also doesn't take into account the accuracy of delivery with target motion issues. It does, as I said, it doesn't take into account extent of disease and so forth. So it also doesn't take into account biomarkers. So it's a useful tool. This is an example of what I mean. This is a nomogram by Catan, who's a statistician, sort of, from Memorial. And these are two different models. This is one that predicts the risk of biochemical failure on the left, and this is one that predicts the risk of bone metastases. And what you can see is that here PSA is, even low PSAs are worth a lot of points. You just put the value in and you take points from above, and T stage is not worth very many points, and Gleason score is not worth very many points. But if you look at the nomogram for metastases, Gleason score gets a lot of points. T stage gets a lot of points, and Gleason score gets a lot of points. So they're more important factors in predicting what's important, which is metastatic disease and death. So, and this is the point I was making about age. We showed some years ago that obviously older people don't live as long as younger people, but most people are not aware of the fact that in patients treated with radiotherapy, we published a paper called age plus or minus 70, plus or minus age greater than plus or minus 70. And it turned out that age is a favorable prognostic factor in people undergoing external beam radiation. And that is actually in some ways more powerful than PSA. So again, these are all factors that really feed into it. So don't be surprised if these models don't answer all of our questions. Now, this is RTOG 0415, which has subsequently been published. This is from the original presentation at Astro in 2023. These people were randomized to either 73.8 in 41 fractions or 70 gray in 28 fractions. No hormone therapy was used. And if you look at biochemical control, the hypofractionated regimen, which was a slightly lower dose, was actually better than the conventional fractionation. And if you look at the alpha beta ratios, assumptions about the alpha beta ratio, it suggests that that difference is explainable by the lower alpha beta ratios, are more consistent with the benefit of hypofractionation. So we have a lot of data to support SBRT for prostate cancer. Some is population-based data. We have retrospective data. We have meta-analyses, and we have randomized trials. Then we're going to talk a little bit about how it's done. I'm going to talk about MR Linux and whole pelvic radiation. Martina is going to really tell you how to do it, but I'm just sort of leading into it. This is one of the population-based studies that looked at SBRT. So here we're using data that's collected basically from insurance information, looking at procedures and looking at the cost. So if you look at, there was a little bit more morbidity with SBRT. This was early on in the experience where people were first developing expertise and using this, and dose constraints and other issues, image guidance and margins weren't very well worked out. But the bottom line is that it's clearly significantly less expensive to society. This is some of the work from multi-institutional studies. This is led by Dr. Keyshawn from UCLA, who's done a lot of work looking at, these are low risk and intermediate risk patients, low and favorable intermediate risk, and then the unfavorable intermediate risk patients doing less well. So with the patients that are unfavorable intermediate risk, those are the patients that we're typically thinking about adding a short course of hormone therapy, and in some cases, even treating the pelvic lymph nodes. This is a big population-based, actually a systematic review using patients from prospective studies, over 6,000 patients, showing biochemical control rates at 10 years approaching 90%. And as you see, the 950 times 4 is slightly more aggressive if you look at the BED calculation than 725 times 5. I favor this particularly in young patients that have low urinary symptoms. Using validated quality of life instruments on this cohort, you can see that urinary function is very well preserved, bowel function is well preserved, and sexual function is fairly well preserved. And really suggests that this is a very highly desirable treatment from an outcome standpoint, both quality of life and cancer-related stuff. This is a retrospective study by Katz, who's one of the people that's done a lot of SBRT, comparing quality of life metrics with urinary function, sexual function, and bowel function in SBRT versus surgery, showing better quality of life, better in terms of urinary function and sexual function, and very little in the way of bowel compromise. So here you see the dip in incontinence with surgery coming up and never getting back, and the effect on sexual function. So there's also been a systematic and other systematic reviews that basically support stereotactic body radiotherapy. At our institution, we did a propensity match comparison looking at patients that got HDR boost versus SBRT boost, and using propensity matching in terms of biochemical control and metastasis-free survival, we see comparable results. So I feel very comfortable using this as an alternative to brachytherapy. We continue to do brachytherapy as well, but I prefer SBRT for my own reasons. Now, we've had some major trials. I'm not going to review all of them. We did RTOG 0938. This is 5 fractions versus 12. Shows comparable results. The PACE-A study is the quality of life study I mentioned early. 5 fractions versus radical prostatectomy with quality of life as the main endpoint. And then the PACE-B is also looking at conventional dose escalation versus SBRT. If you look at the PACE-A study, again, urinary continence, a big issue with surgery, and sexual function, a big issue with surgery, suggesting that not only is conventional radiation better in terms of quality of life, but SBRT is better in terms of quality of life. This is from the PACE-B study. This is a magnification of this, but if you look at biochemical control, it's comparable. If you look at GI toxicity, if you look at GU toxicity, again, comparable. So instead of treating people with 39 or 40 sessions, this study, you can treat people with 5 treatments, a much more convenient approach. Martina is going to dig deeper on this. These are some of the dose constraints that we use. And again, these were designed to basically mimic what we were doing with high dose rate brachytherapy, both as monotherapy and as a boost. When we generate a plan, we tell patients, oh, we're going to do a plan. This is what the dose distribution. I consider this plan a promise to the patient. This is what we are going to do, as opposed to, sort of hand waving. And to make sure we do that, this is why we do image guidance. This is why we use fiducial markers, so that every day the treatment is supposed to look like what it said on the paper and in the computer. This is from a study done at MD Anderson, and I wrote an editorial on this study. Was published back in 2005. So many years ago, when we first started doing 3D dose escalation studies, we adopted a policy of simulating the patients with the bladder full and the rectum empty. And our hypothesis at that time was that by doing that, if during the course of treatment, the patient had more gas or something and moved the prostate forward, it would simply increase the margin around the back and you wouldn't underdose it. And yet it would keep the dose to the rectum to a minimum. The folks at MD Anderson did not do that. And what happened was subsequently they, and I don't know why my mouse is so jumpy today, but anyway, they retrospectively went back and looked at what happened to patients based on their initial CT scan. And what they found was that patients that had a distended rectum at the time they were simulated had less toxicity. So when the rectum became empty, the prostate, the rectal dose was reduced because the prostate moved posteriorly because they weren't using image guidance. They didn't have fiducial markers. The patients that had an undistended rectum had more toxicity, but they also had better biochemical control. So you really need to control what you, how the patient is simulated. And I recommend the rectum be empty. And if they're too distended, that you can use a tube, you can take the air out, you can give them an enema, you can re-simulate them. But this is part of the reason that for more than 30 years, we've been using fiducial markers, or close to 30 years, we've been using fiducial markers, which allows you to compensate for that if there are setup changes. This is one of the first papers that we wrote, so about 20 years ago. This is looking at patients that had morbid obesity. We only had 3 patients, and yet we got this published in the Red Journal with no comments. That's a rare thing. You submit a paper, they say yes. So what we showed was that if you took a patient that had morbid obesity and you used the tattoos and you didn't have fiducial markers in the prostate, you could actually miss the prostate completely, because you can move the skin any way you want with the tattoo and it doesn't have anything to do with what the prostate's doing. It's hard to tell from these images, but there's a lot of uncertainty in if that's what these were mostly left, right. They were left, right, soup, anterior, posterior, all kinds of motion was there. So we adopted this policy more than 20 years ago of routinely placing gold marker seeds in the prostate. We usually put one in the base, one in the midgland, and one in the apex. And this is an example of an old-fashioned 3D plan. We used to use a 6 or 7 field technique and eventually evolved and adopted this with IMRT. Alvaro Martinez's group had adopted a policy instead where they would do online imaging on the first few treatments, and then subsequently they would assume that they had captured all of the inherent motion that might be seen. And what you're seeing on the top is that approach versus using it all the time. So the bottom line is that if you really want to get tight, accurate treatment, you need to use image guidance every day, not just at the beginning to see how much motion is going on, but image guidance every day. This is an example of a patient that I treated years ago. I think I have. This is a patient that had a radical prostatectomy, and he had a recurrence, and he had a nodule, and his PSA was 0.4. And there's a seed here and a seed here around the nodule. And on the lateral, you can see the seed here and seed here. and this is contrast in the urethra. So after he had had a few treatments, the therapist said, I thought you said we put gold seeds in there to guide the treatment. And I said, we did. And it turned out that they hadn't used the seeds and they missed it. They missed the nodule for the first 2 treatments, and we subsequently added a boost to compensate for it. But this is part of the reason that people recur after post-op radiation, is that you can miss the anastomosis because you don't use fiducial markers, and we use them in our post-op patients as well. This is from a study where we studied that in patients after radical prostatectomy. So we looked at 163 fractions. This is right, left, inferior, superior, anterior, posterior. And so about 40% of the time, there was a shift of greater than 5 millimeters, which meant that you were underdosing the target and treating normal tissue. So image guidance, whether you're doing IMRT or SBRT, is important, and it's even more critical with SBRT. This is from a review article we wrote on SBRT. So we have a gold seed placed at the base, one at the midgland, one at the apex. We then do fusion using VIBE or T1 images and between the CT and MRI. And then we do planning based on the CT. This is using the CyberKnife with hundreds of beams. And we get very elegant dose distributions. Now, this is an example of a patient, 63-year-old with unfavorable intermediate risk. His PSA was 8.8, his Gleason 4+3. And here you see there's a seed here, and seed here. We're localizing the seed on the CT. This is the VIBE image. This is a VIBE, a T1 image. We localize it, and then we do fusion, and then we use the T2 images to define the anatomy for purposes of defining the urethra. This is an example of the dose distribution. The urethra is identified in order to make sure there's no hot spot in the urethra. We keep the dose less than 120% of the prescription dose. This is an example of a patient with a distended rectum. You can use what we call a red robin or a red tube to deep compress it. You can repeat the simulation, or you can proceed with guidance depending upon how much distension there is. One of the more challenging areas is when a patient has a median lobe. This is where it's usually benign. It bulges from the prostate into the bladder neck area. And sometimes people think this is the prostate when it's the prostate pushing up the bladder wall, which is sitting on top of it. And sometimes you can overtreat that part of it and cause some morbidity. So I usually sort of split the difference and sort of compromise the coverage there in order to reduce the urinary morbidity. You can see here, these are the seminal vesicles. We usually cover the proximal centimeter of the seminal vesicles. This is the median lobe, part of the median lobe of the prostate. And these are fairly similar cuts, but you can see how the motion can affect the location of the prostate. So here's a question. Which of the following statements is not true? The use of fiducial markers have been shown to improve the accuracy of IGRT when performed daily prior to treatment. Rectal distension at the time of simulation has been shown to be associated with a higher risk of PSA recurrence. Obese patients are most likely to benefit from image-guided radiotherapy. Daily image guidance has not been well studied in post-prostatectomy patients, or 5, all of the above are true.
So let's wait until approximately 80% answers, because that's how we take attendance.
Okay. We're getting close.
Yeah. So almost there. A few votes. Awesome. So we have 79, 82%. I'm ending the poll, sharing results. So majority answered, let's see, it's actually split between B and E.
Is
So
that, you mean, and
2 or 5.
okay. Well, it turns out that the one that's not true is daily IGRT has not been well studied in post-prostatectomy patients. It has been studied, and we showed an example of the paper that we published to show that it was done. 2, rectal distension was the paper from MD Anderson that showed that rectal distension was associated with a higher risk of biochemical failure. And since 4 is the one that's not true, then 5 can't be the answer. So 4 was the correct answer, that daily eye is not true. We've studied it in post-op patients, and image guidance should be used in all patients treated with radiotherapy.
Okay, thank you. You tricked everyone.
Well, most people don't use image guidance in post-op patients. That's why I like to put it in there.
Yeah,
because that's why some people fail salvage radiation.
Mhm.
Now I'm going to shift. This is a paper that was published in JAMA. JAMA is one of the most prestigious journals of all in medicine, Journal of the American Medical Association. This was a randomized trial that tested whether MR-Linac SBRT improved physician-scored genital urinary toxicity when compared with standard, what they call CT guided. And they were looking at acute GU toxicity measured by CTCAE4. Now, the first part of this, I'm going to start to share my perspective. This is not actually CT guided. The guidance. This is a linear accelerator, and it's guided by electronic portal imaging. So it's a portal imaging guided, and the MR is guided by the MR. So they had a 1-to-1 randomization. They used 4 millimeter margins on the CT arm and 2 millimeter margins on the MR arm. And they gave 40 gray in 5 fractions. The standard dose is, there are a lot of people that use 40 gray. Usually when you use 7.25, it's 36.25, or if you use 9.5, it's 38. So this, it could be how they just defined what their volumes were, but that's a slightly higher dose than usual. The study was closed by the Data Safety Monitoring Committee before they recruited all the patients, because they reported that grade 2 or higher urinary morbidity was lower on the MR group than in the CT group. And they said the incidence of acute gastrointestinal toxicity was also lower. And there was a change in the urinary symptom score. And so this is considered to be a positive trial, establishing the fact that, and in fact, there were people at NCCN that wanted us to now change and say this should become the standard of care.
Interesting.
But here are the problems. Let's do a thought experiment. Let's say we did a randomized trial where we treated the same patients either with a 2 millimeter margin or a 4 millimeter margin. If the people with the 4 millimeter margin, and this is the volume that's being irradiated as a result of these margins, because these people had more toxicity with a bigger volume irradiated, does that mean that this MR machine is better than the other MR machine? It's the margins. So how do you use different margins on you with CT guided to argue that the MR has become the standard of care? Their rationale was that it was safe to use 2 millimeter margins with an MR machine, but the CT requires 4 millimeter margins. I can assure you that we don't routinely use 4 millimeter margins everywhere. You don't need to use the same margin everywhere. You can customize the margins to suit the anatomy and the clinical circumstances. So that's a problem. So it's the same argument can be made. I mean, the example I gave before were identical machines, and the same is true whether the machines, even if the machines are not identical. But here's the other problem. The MR machine took 1,133 seconds to deliver the treatment, and the CT required 232 seconds. So it took 5 times as long to do the treatment with the MR guided treatment. Therefore, the patient had more opportunity to have motion. If you set the patient up, what they wanted to argue is that with the MR, you don't need fiducial markers because you're going to image the patient with the MR machine, while with the LINAC, you need to use fiducials to do the treatment. But they don't, and the idea is that they're doing adaptive radiotherapy with the MR machine. But the problem was they only adapted, they only made a change if greater than 10% of the prostate volume moved outside of a 3 millimeter gating boundary. So they allowed up to a 3 millimeter gating, they let 10% of the volume to go outside of it, up to a 3 millimeter gating boundary. They don't tell you how often that happened, but that was likely to happen more because it took longer for the treatment to be delivered. In addition to that, if you look at the doses they used, the doses were higher than typically used on other studies. I talked about the study earlier that had over 6,000 patients. 90% of the patients received a dose of less than what they did on this study. In addition to that, they allowed people to do a simultaneous integrated boost to the dominant intraprostatic lesion if they chose to. So for people that had more advanced disease, more discrete, a nodule or so forth, they could actually give even more than 40 gray. And it turns out that, and as I'll show you in a minute, there were more high-risk patients on the CT arm than there were on the MR arm, more patients with high-risk factors. So if you looked at the patients that got the CT guided treatment versus the MR guided treatment, 39% were high or very high risk. That would imply that they're more likely to get these boosts, that sort of thing. They used rectal spacers on more of the patients that got MR guidance. If you believe those things work, maybe that would be a bias. They had more baseline GI comorbidity in the patients that got CT guided. And if you add up all of these things, there were 93 patients that had these things compared to 93 factors of these things in this population of 77 patients versus 74 in this population of 79. So there's an inherent imbalance in terms of risk factors and things that might be expected to be associated with more morbidity. This is an interesting study that looks at observer bias in randomized trials with measurement scale outcomes, a systematic review. So let me clarify what this is. They looked at all the literature in which they had blinded and unblinded assessments of outcomes. So this JAMA article with MR guidance is not blinded because the patients knew if they got MR guidance or not, and the doctors knew if they got MR guidance. And this was a single institution study where the doctors were hoping to demonstrate that the MR was better. And what this study shows is that when you have subjective and you have blinded and unblinded, that there's an exaggeration of the effect by 68%. So when you have blinded, when you have unblinded, that's more unblinded results are at the top, it favors benefit of treatment. But when you do blinded studies, that disappears. So this is an unblinded study, which means it was predisposed to observation bias because the primary outcome was physician-reported outcome, toxicity. The other thing of concern is that when you ask patients versus doctors about side effects of treatment, the doctors will say, you know, he didn't have too many, he wasn't too bad, he didn't have a lot of frequency, nocturnal urgency, dysuria, incontinence, rectal, all these things. Yeah, it was pretty good. And then you ask the patient has much higher side effects than the doctor's report. So there's always, you know, when you use physician reported outcomes, there's a potential for bias and error. Now, in this particular study from JAMA, it turns out that the physicians reported more side effects than the patients did. Okay, which is the opposite of what you would expect. Patients say they had more frequency, nocturia, urgency than the doctor said they had. But in this JAMA article, the physician said, oh, look at this. The grade 2 or higher GU was worse in the CT guided treatment. But when you ask the patients from the same study, you don't really see any differences. That tells you there was substantial bias. You also have the opportunity for placebo effects. So the patients knew that they were getting MR guidance and they expected, the hypothesis was that MR guidance was supposed to be better. This is an example of how bias can affect results. So this is a study. They took patients that were receiving seizure medication, and this was placebo versus active agent. And 13% of patients thought they had a greater than 50% reduction in their seizure activity with placebo. So we know that even the patients would be likely to suspect that they have less side effects from MR guidance. So the bottom line regarding the Mirage trial is that it was a flawed design with flawed margins, flawed outcomes, and with substantial evidence of bias, not to mention the known higher costs. Subsequently, this company went out of business. But the bottom line is, don't believe the hype. You don't need MR guided guidance to do SBRT. Now I'm just going to show, I'm just going to have a few more slides left. This is a example of, here's a gold seed. Here's a margin around the apex of the prostate. This is a sagittal and a coronal image. I'd always like to, when I'm looking at structures, look at all three, not just axial slices. Well, when we treat pelvic nodes, we like to go up to L4, L5. In the old days, we went to L5, S1, but we have more contemporary data that suggests the common iliacs are a common place where people fail. So in our newer study, we go up to L4, L5. We covered the internal and the external iliac nodes. And it's important to make sure you understand the nodal, the nodes and the various definitions. This is a really good reference. And there are other good references out there that tell you exactly which nodes you're talking about. I don't usually treat the groin nodes unless there's some unusual circumstances, but they're infrequently involved. We know that most the external iliac nodes, the internal iliac nodes, the presacral nodes, the common and the periaortic nodes, these are the most common areas. This template is a good way to go. When you treat patients that are post-op patients that underwent radical prostatectomy, you need to understand that the urologists do not sample any nodes in the presacral area or periprostatic nodes. They frequently will do only they'll do a node sampling related to mostly the obturator nodes and the external iliac nodes. Some people have chosen to, instead of doing conventional fractionation with treating whole pelvis to 4,500, to use ultra hypofractionation in treating the pelvis as well. This is a study where they deliver 5 fractions, 5 times 5. They had 171 patients in this report, and the authors claimed that the overall pelvic control rate was 98.2%. Well, that doesn't really, here's one of my favorite quotes: you can fool all the people some of the time, and you can fool some of the people all the time, but you can't fool all the people all the time. You can't fool me with this 98.2% because it's inconsistent with what we know about how you should evaluate the effectiveness of pelvic radiation. They report good cancer control rates, but the follow-up is relatively short. If you look at 5 years, their median follow-up was relatively short. And they also gave people hormone therapy. So when you give people hormone therapy, you can't assess what the pelvic control rate is early because it takes a while for their testosterone to come back. And even if they failed in their pelvic lymph nodes, you may not know it for a while until the testosterone comes back. But here's the main point. We will know whether there's benefit to whole pelvic radiation. I'll be presenting some of this data at ASTRO in end of September. But you can't, when you say you had a 98% control rate, that only makes sense if you had 100% of the patients with microscopic disease, and then you assess how many failed. If you only had, if only 20% of the patients had lymph node involvement, then your failure rate would have to be multiplied by 5. That would immediately go up to 15%. In other words, if you have no patients with lymph node involvement, you can't claim that you have 100% pelvic nodal control because you can't control something that wasn't there in the first place. So they assume when they use that number, 98.2%, that everybody had cancer in their nodes, and they only have a few percent of patients who fail. The other thing is that they also, in follow-up, they did PSMA PET to evaluate whether people failed in their pelvic lymph nodes, and PSMA PET is only 40% sensitive. So that means that significant number of people could have failed in their nodes that they didn't show up on PET. So because of the problems with lack of testosterone recovery with hormone therapy and so forth, we really don't know how effective this regimen is. Now, we do know that it seemed to be well tolerated, and this is actually a randomized trial that's been published comparing that regimen 500 times 5 versus conventional fractionation, and at least from a quality of life standpoint, it's reasonably well tolerated. And I have used it in the past, but I don't think it's safe to say that we know whether anybody needs whole pelvic radiation who's got unfavorable intermediate risk and favorable high risk. If they're very unfavorable, I highly recommend it, but we will be answering the question in the near future. This is just to support the assertion I made that the PET positivity, the sensitivity of PET is only about 40%, about 40% sensitivity. So you can't use the PET imaging to tell whether or not patients have failed in the pelvic nodes. So my final conclusions are the value of pelvic radiation remains unknown. Optimum fractionation may be 0. It's important to recognize the truth and avoid dogma. These slides are just to touch on some questions with hormone therapy. If you do SBRT and you think the patient needs hormone therapy, this is a study where we looked at sequence of hormone therapy. Is it better to give it the hormone therapy before or after the radiation? If you do prostate-only radiation, which is the red line, the black line is prostate-only radiation followed by hormone therapy. The red line is hormone therapy first and then prostate-only radiation. In this randomized trial, If you do prostate-only radiation, it's better to give the hormone therapy after the radiation. So if you're going to do short-term hormone therapy, you might, this is the only data available from a randomized trial, you might want to include that in your regimen. This is some work that is from UCLA, and this is using microRNA. These are SNPs, single nucleotide polymorphisms. So what you do is you have the patient submit a swab from their cheek, and they're able to run, this is these SNPs, and this is conventional radiation, and this is grade 2 urinary toxicity. So they claim that they have developed an assay that can predict which patients are likely to have toxicity with conventional fractionation. These people have this signature, and with SBRT, these people that have a different signature will have also an increased risk of morbidity. So I've actually started to use this in some patients where I will check their SNPs to determine whether they're predisposed to develop more side effects with SBRT or more side effects with conventional fractionation. However, this work really needs to be validated, and we hope to continue to do some work to validate that. So here are my take-home messages. Definitive radiotherapy, when well administered, appears to be at least as effective as radical prostatectomy and has a better quality of life. Early results with biomarkers are encouraging, but we need more work in that area, and ultra hypofractionation should be considered when possible, but it's critical to have high quality control. You need to understand the anatomy. You need to do good image guidance. You need to respect the dose constraints and select your patients appropriately. Thank you very much for your attention, and I will turn it over to the next outstanding speaker.
Thank you so much, Dr. Roach. That was an excellent lecture, and thank you for giving us also some hints and guidance how to not design a clinical trial.
Okay.
That was a very good lesson. Thank you. Martina, would you like to share? And Dr. Roach, you can stay until the end of the lecture, correct? To answer questions?
Yes.
Yeah,
Yes.
excellent.
Yes.
Thank you.
Okay, do you see the slides?
Yes.
Fine? Okay, perfect. Thank you very much for the invitation. I'm really delighted to be here. I'm going to be covering the physics aspect of prostate SBRT, including simulation planning and treatment delivery. So this is the outline of my presentation and learning objective. So we'll discuss physics consideration, including simulation, patient immobilization, multimodality image registration, how do we define RT structure, beam design and optimization, plan evaluation, consideration for motion management and treatment verification. So as we heard, there are like many different modalities that can be used for prostate SBRT, and there is not a particular modality that provides better results than other. These modalities have different characteristics in terms of beam arrangements. For example, on the Linac, you typically use isocentric and non-coplanar beam, while for the CyberKnife, we use non-isocentric and non-coplanar beam. And this modality differs in terms of the dose distribution that are given to the PTV, more homogeneous versus heterogeneous. Particle therapies has also been used to deliver prostate SBRT, and there are various IGRT modality that can be used for patient setup and treatment verification and also online adaptation. Each modality might have specific workflow, but this is what typically is performed in the radiation oncology department. First, we have fiduciary implantation, typically 1 week prior to patient simulation, that the patient undergo CT simulation and MRI imaging, which is particularly important to delineate the prostate and the urethra. We perform image fusion, target and organ at risk delineation, treatment planning, and then chart check, patient-specific QA, and patient alignment and verification. As Dr. Roach discussed, we implant typically 3 fiducials in the patient. 3 to 4 fiducials are needed if we do both translational and rotational correction. In particular, for CyberKnife treatment, where we do online tracking, the fiducial have to be at a distance of at least 2 centimeters, and they cannot be collinear. So we need to have a good fiducial configuration in order to track both translations and rotation. And you can see here the 2 fiducial at the base and 1 fiducial at the apex, which is typically implanted. In terms of patient simulation, as we heard, we simulate the patient with an empty rectum, and most center would do full bladder, because if you have a full bladder, it's easier to get good dosimetry. If the bladder is full, you have a larger volume. For CyberKnife patient at our center, we do empty bladder because the treatment time is longer, 30 to 40 minutes, and so the patient is more comfortable with an empty bladder. So that's what we have been doing here. In terms of immobilization, we have a vac bag or body frame if the patient is treated on Linac. And if there is intrafraction monitoring during treatment, we can just have the patient set up with a knee sponge and foot block, which is more comfortable if we don't, with the arms away from the irradiation volume, so arms on the chest with ring and a head holder. For SBRT, we need a CT protocol with 1 to 1.5 millimeter slice thickness, because gives more accurate dose calculation and also more accurate IGRT parameters. So the best modality for contouring the prostate and the urethra is an MRI T2 image set. But since the fiducial appear as hypo-intense in the MRI T2, we do a registration between a T1 MRI, identifying the fiducial in the axial slices, and do a 3-point rigid registration between the fiducial on the CT and the fiducial on the T1. The T1 and the T2 are in the same reference frame, so they're automatically co-registered to the planning CT after we do the image registration with the T1, and then we can contour the prostate and the urethra on the T2, and here just like the axial and coronal slice. Then for the CTV includes the prostate plus or minus 1 centimeter of the proximal seminal vesicle, and we add margins to the CTV to generate the PTV. We also put a margin on the urethra, typically 2 millimeter margin on the urethra, and we try to meet the urethral constraints on the urethra PRV. All other structures are contoured on the CT because we do CT-based planning, and so we contour bladder, rectum, bowel, and colon, pineal bulb, femoral head, skin, and the genitalia on the CT. And the genitalia is used for non-coplanar beam arrangement as an avoidance structure. We don't do beams through the genitalia. So the margin are different for different IGRT technique. A common margin that is used for Linac-based treatment is 5 millimeter isotropical with a tighter posterior margin, but the margin can be reduced to 2 to 3 millimeters in case there is an online monitoring technique during treatment. So this is the case for the CyberKnife with fiducial tracking, and the tomotherapy that adopted the same fiducial tracking system as the CyberKnife, and as we just heard, for MR Linac capable of gating with the margin was reduced to 2 millimeters, and also electromagnetic. The Calypso electromagnetic beacon have been used for tracking and gating the prostate during treatment. In terms of planning consideration, one has to account for the proximity of the organ at risk, anatomical variability. We need to achieve high dose conformity to the target and steep dose gradient, and be mindful of the location of the hotspot within the GTV and the dominant intraprostatic lesion. Various dose and fractionation schemes have been reported, and here I mentioned this study because it's a really good reference guide for starting a prostate SBRT program. They report all of the dose and fractionation that are used in clinical trial, and also the dose constraints that have been used for those trials. So it's a good reference to have. As Dr. Roach mentioned, we adapted the constraint for our CyberKnife treatment. We started treating SBRT prostate patient on the CyberKnife in 2006, and we borrowed the constraint from our long HDR experience. In this paper from Dr. Fuller in San Diego, was really kind of like formed the basis for the non-homogeneous prostate protocol, where they compare HDR and CyberKnife, and they observe that basically with the CyberKnife, you can obtain this similar shape of the dose distribution compared to HDR treatment that had a long history. And so if you see the hotspot, the orange line, the 125% hotspot, the yellow line is the prescription dose, and the green line is the 75% of the prescription dose. The shape is similar in the two modality. In terms of PTV coverage, in this dosimetric comparison, they achieve comparable PTV coverage. The hotspot was obviously higher for HDR because of the nature of the inverse squared law, where you have a very extreme radiation dose in the proximity of the dwell position. The bladder Dmax was higher in HDR because of the proximity of the dwell position close to the bladder, but they achieve similar Dmax for the rectal mucosa, and actually slightly lower D10 on CyberKnife, again for the rectal mucosa. And so when we started, we really adopted this constraint, and there are other those regimen that were used at San Diego, Erasmus, that have this non-homogeneous dose protocol following the HDR with prescription isodose line in above 50%, 60%. And for our constraint for bladder and rectum, we use Dmax of bladder and rectum less than 100%. And we look at the V75 for rectum and bladder and try to keep those less than 2 cc and 3 cc, similar to what we had in HDR. And this again is a more homogeneous dose protocol, 36.25 in 5 fraction, and particularly if this is delivered on LINAC, the dose distribution is much more homogeneous with the prescription isodose line in the high 90s. This is an example of a CyberKnife plan with a non-coplanar beam arrangement. We often use 38 gray in 4 fraction. CyberKnife has a single 6 FFF beams. This plan had 161 beams. Commonly, we have like 100 to 200 beams, 71% prescription isodose line, and longer treatment time, because again, typical treatment time are 30 to 40 minutes. And here are the dose objectives for all of the organ at risk. The urethra PRV, we keep the urethra PRV less than 120% of the prescription max point dose, and V75 for bladder and rectum are less than 2 and 3 cc. And this is just an example of the, from this plan, the TVHs for the prostate, the PTV 38, the urethra PRV, bladder and rectum. And we also treat patient on LINAC-based SBRT. We typically use 2 coplanar arc with VMAT 10 FFF beams. 40 gray in fine fraction to the prostate, the PTV40, and the PTV that includes the seminal vesicle goes to 36.25. High prescription isodose line, and these are the dose objective that we use in the case of LINAC-based SBRT with the DVHs that show a much more homogeneous dose to the PTV compared to our CyberKnife plans. We develop a standardized approach to those constraints, and this really helped to have more standard plans with different planner and have a systematic approach. So the anatomy, of course, should influence the constraint that we use for bladder and rectum. For patients with a small prostate, with a small interface with the bladder and the rectum, we should expect to have a better value of V75, while patients with a large prostate and large interface must be difficult to achieve value below the constraints. So to quantify the interface between bladder and prostate and rectum and prostate, we use this expansion intersection volume that is basically the rectum and bladder expanded by 5 millimeters and intersected with the prostate. And we look at a cohort of CyberKnife patients that we treated, 25 CyberKnife patients, and we look at the distribution of the total V75 as a function of the EAV. So we developed this very simple formula to know for the patient that have a more favorable anatomy, what V75 for bladder and rectum can be achieved. And since it's a global parameter, the planner can prioritize sparing out the bladder, since we see more urinary toxicity for bladder compared to rectum. And also, I want to note that for patients with a large prostate, we can meet the constraint at the expense of a more heterogeneous dose distribution. The hotspot for patients with a large prostate are larger because we need to accomplish a steeper dose fall-off to meet the V75 constraints. In terms of tools for plan evaluation, the distribution has to be evaluated everywhere, particularly if we use non-coplanar beams, because there can be dose spillage far away from the target. Perform, of course, a DVH analysis and look at the dose objective, and look also at the dose conformity. So the conformity index is a dosimetric parameter that enables to establish whether there is a perfect conformality between the prescription isodose and the target volume. So in the normalized conformity index, you have a normalized conformity index equal to 1 only if there is a full overlap between the isodose volume and the target volume. Another parameter that we look at is the dose gradient. The dose gradient is the volume receiving half of the prescription divided by the target volume, and a dose gradient less than 3 is a good gradient. For prostate, typically we achieve conformity index, normalized conformity index between 1.1 and 1.2 is still good. And of course, evaluate the hotspot. Hotspot within the target may be desirable. There are a lot of dosimetric studies that compare CyberKnife versus LINAC and other modalities. There are a lot of studies and a lot of differences in the results of the studies. And it's really hard to make an objective dosimetric comparison because it depends on how the target were contoured, the anatomy of the patient were contoured, the skill of the planner. So I selected a few to review here, but I think from all of these studies, we can come to the same conclusion that all of the modern modality that can deliver prostate SBRT are adequate. And so, although we started with CyberKnife and early studies started with CyberKnife, LINAC-based SBRT has just as good dosimetry as CyberKnife. So this was a very, very early study that we published in 2010 comparing CyberKnife to 9 fields IMRT, and was a retrospective planning study. All of the plan were able to meet the dose constraint, and CyberKnife plan achieved better dose conformity and higher dose homogeneities, of course. And if we look at the DVHs for bladder and rectum that are reported here, in our study, we saw that actually MRT had the lower, higher low dose DVHs compared to CyberKnife. The CyberKnife is in blue, and in red is the IMRT. But the study actually shows the opposite. Was based on 27 patients, and all of the plan were performed with the same margin and the same dose objective in all of the study that I'm going to review. So this study compare tomotherapy, sliding window IMRT, VMAT IMRT, and CyberKnife. And again, in terms of conformity and homogeneity index, CyberKnife provided better homogeneity, higher homogeneity, dose heterogeneity, and better conformity, but higher dose to the rectum. In this particular case, the sliding window IMRT provided better sparing of the rectum. In this paper, they also perform NTCP study, and for the bladder NTCP, they didn't see any advantage of one modality compared to the other. And this is another study that compared CyberKnife, RapidArc, VMAT, and non-coplanar IMRT. And again, this is the cumulative DVHs. If you look at the PTV DVHs, you see that the typical CyberKnife non-homogeneous dose distribution with higher dose to the PTV compared to the steeper drop in PTV dose of the other modalities. And in this particular study, they observed that at the low part of the DVHs, the dose was higher for CyberKnife compared to the other IMRT modality. But the author concluded that the dosimetric differences were marginal, and the technique of choice should focus on delivery accuracy, on the availability of online image guidance, and not specifically on the dosimetry. And it's interesting to see the dosimetric comparison from the PSB study that Dr. Roach just discussed. So in the analysis, it emerged that the patient treated with CyberKnife, this 164 patient, had actually lower urinary toxicity compared to the patient that were in the LINAC cohort. And so it was interesting to look at the dosimetry of the plans, and what emerged was that the CyberKnife plan had higher dose to the urinary structure compared to the LINAC plan. And the conclusion was that probably the lower side effect was due to the intrafraction tracking capability of the CyberKnife compared to LINAC. And so also the trend to lower GI side effect was due to the smaller posterior margin of CyberKnife plans compared to the LINAC beds. So the anatomical variability has to be accounted for when treating prostate SBRT. We know that the prostate moves, but also that there are substantial anatomical changes during treatment. In this study, we took a patient that received a CyberKnife boost and also IMRT on the tomo. So we had the daily MVCT from the tomotherapy treatment, and we recompute the CyberKnife dose on the daily MVCT. So if you look at the image A and B, you see the differences in the rectum contour from the plan to the delivery of the day. So if you recompute the CyberKnife dose onto the day of MVCT, you see that there is a substantial portion of the rectum that receive high doses of radiation. And the same is true in the case of the bladder. The CT scan from the planning versus the daily imaging. So treatment adaptation and robust planning technique should be used to mitigate the effect of anatomical variability. There are different techniques that can be used to verify the patient setup and verify that the prostate it's properly aligned with fiducial tracking. You can use planar 2V images or cone beam CT, in which you also see the anatomy of the patient. You can correct for translation only or translation and rotation, depending on the SBRT image modality that you're using. So it's well known that the prostate move during treatment, and this is an old study that was performed with the Calypso system. Calypso is this EM beacon implanted in the patient, and in this study they reported the traces of prostate motion as a function of the treatment time for different patients. And the blue is the left-right motion, the red and the green are ant-post and SUPIF, and the black is the magnitude vector. So different patients exhibited very different motion of the prostate during treatment, and if this motion is not accounted for, it's hard to deliver the planned dose to the patient. In some cases was like a drift, an erratic motion, more like not really reproducible type of motion that cannot really be modeled or accounted for unless you image the patient during treatment. And IGRT option include the Calypso beacon, gated trigger imaging on LINAC, MRI, sagittal cine imaging, and CyberKnife tracking with fiducials. I'm just going to review how CyberKnife tracking work in the interest of time, and also because it's the modality that we use here. So the image guidance for CyberKnife system consists on the two X-ray sources on the ceiling with corresponding flat panel detector on the floor, imaging the patient in this 45 degrees view. The fiducial are identified in the DRR that are generated from the planning CT. And at the same time, every 30 to 60 seconds, live X-ray images are acquired, and there's an automatic fiducial registration between the live camera image and the DRR. And based on this registration, the couch correction parameters are calculated that gives both translations and rotations. And these offset are fed back into the robot that corrects basically for the prostate motion during treatment and points to the actual target location. If those shifts are greater than 1 centimeter, then the patient has to be repositioned. So that's the question is, what images are best suited for prostate and urethra delineation? CT scan with 1.5 millimeter, CT scan with 3 millimeter slice thickness, T1 weighted MRI, or T2 weighted MRI?
Okay, we almost have 80%. Okay, excellent. I'm ending the poll, sharing results. So majority answered, 42% answered D, T2 weighted MRI.
That's correct.
Excellent.
We mentioned it a few times during the talk, so
people got it. Thank you.
yeah, that's what I have.
Thank you so much, Martina. That was very great. It was very very educational, informational, lots of good information for people in Ukraine to start SBRT programs and with prostate. I have a question regarding, so you mentioned all these technologies, right? So majority of technologies is Linac based, right? So there's only one CyberKnife in Ukraine. And you mentioned that for CyberKnife, you don't do empty, you don't do full bladder, you do empty bladder, but for Linac, you do full bladder because the treatment is shorter. That's
Yes.
correct?
Yes,
Yeah.
that's correct. Dr. Roach, do you want to add something on this since
Oh,
versus full bladder, one of your favorite topics?
yeah. So there are people that routinely treat patients with there are a lot of people actually that recommend treating the patient with the bladder empty. And there are other people that recommend full bladder. I usually use full bladder for IMRT. I use full bladder for whole pelvic radiation. The problem with a full bladder, if their bladder is too full and it takes 35 or 45 minutes, sometimes they can't hold it for the whole time.
Yeah.
And then they
move.
Yeah, they move or they wet on themselves, and it's not a good look. Our therapists prefer to do it with the bladder empty.
Okay.
So we usually do the bladder empty, actually. But we're using fiducials, and we're tracking, so we think that that's going to be more comfortable for the patient.
Okay. Okay. Thank you. And I was thinking about Ukrainians and thinking how to start for them. Only 10 departments out of 42 currently do prostate SBRT. So we'd like more and more people to start doing prostate SBRT. There's one major obstacle, the surgeons, they would rather do prostatectomy. So another big obstacle is no fiducials. Typically, they don't get fiducials implanted, or maybe access to MR. Also that can be a challenge, and monitoring intraprostatic motion during treatment. So that can be a challenge. Do you have any suggestions, Dr. Roach, how to start for them? You started a long time ago. Maybe not all these technologies were available, but.
Well, I mean, it's really, if you can find urologists who understand. I mean, there are patients that are not candidates for radical prostatectomy or don't want it.
Right.
Now, the key, I don't know what your reimbursement structure is like. Do you have, I don't know how healthcare is reimbursed in Ukraine.
It's all covered, so regardless.
Well, in the US, they created a code to pay the urologist to put in the gold seed.
Oh, interesting. That's good. I don't think
so if the urologist gets paid, and if you look at what they get for a biopsy, I think what they get for putting in gold seeds is probably similar to what they get for a biopsy. So if you find a urologist that will work with you, in some places the radiation oncologist puts them in themselves, which is a solution, especially if you have experience doing brachytherapy, then you may have some experience with that. I don't put them in myself. I don't like the idea of putting them in myself because I like the idea that I can keep the urologist engaged and involved.
Oh, okay.
And that's also true in post-op patients. So if there are papers published on it. So if you're doing academics, you might want to, but the main thing is if you can find a reimbursement code, then you can probably find a urologist that wants to get paid to do it.
Okay. I think they would be paid more for the surgery. So
well,
I think that's the argument.
Some patients don't want surgery.
That's true. Or some patients are not eligible, right?
Right. But see, here's the other thing is that if the patient decides they want radiation, and then you ask the urologist to do it, then the urologist is going to get paid when they wouldn't have gotten paid without doing it.
Yeah.
So the money certainly is going to be a factor. Somebody asked me a question about the seminal vesicles, about 1 cm what case do you include them? And I sent this equation. There's a Roach equation for lymph node involvement. There's also a Roach equation for seminal vesicle involvement. It's the PSA plus the Gleason score minus 6 times 10. So if you have a patient whose PSA is 5 and their Gleason score is 7, 7 minus 6 is 1 times 10. So then their risk of seminal vesicle involvement is around 15%. Then what I do is I look at the distribution of their biopsies. So if all their biopsies are positive in the left lobe, I don't even treat the right seminal vesicle, I just treat the left seminal vesicle. And when you treat one seminal vesicle, you substantially reduce the dose to the rectum.
True.
So I sort of customize it based on their risk of seminal vesicle involvement in general. And then I take into account their distribution. And if they've had do you guys have PSMA PET?
I believe only few places use it, maybe only one.
Yeah, if on PSMA PET or MR imaging, the disease seems to be on one side, then I would also consider not treating the seminal vesicles at all or only treating one side. Because the seminal vesicles move, they're mobile. So you don't want to make a big margin around the seminal vesicles. You'll miss them anyway, and you end up hitting the rectum instead.
There's another question also from Sergei Filkovsky about fiducial markers. So after implanting the fiducial markers, medical physicists check the distance and angles between the seats. And if the distance is small, physics asks to implant another one, or the doctor do this himself in the clinic. Have you ever put 5 seats, or your chances of putting them incorrectly then minimized?
Okay, so let me clarify. The CyberKnife requires you to have the seeds a certain distance apart and not be in the same plane in order to use all the rotation that you might consider. When you do Linac-based SBRT, it doesn't have the same restrictions. And you can use, if you put in 4 or 5, it's okay. But all we really need is 3, and ideally they're well distributed. And no, they don't have to be that precisely placed. And they don't have to measure.
4. We usually do 4. We usually do 4 at Stanford.
Yeah, well, 4 is good, but 3 is. I mean, we treat some patients who only have 2.
Yeah.
You know, because you have orthogonal images, and we don't want to send them back to the urologist. But I'm saying that our goal is 3. 4 is probably a little bit better, although frequently we end up discounting one of the seeds because the alignment may be better with 3. It depends, you know, if the seeds end up in a vessel, they can move. If they end up in the seminal vesicles, they can be ejaculated out. I mean, no. So you want to make sure that they're in the prostate parenchyma rather than around the prostate.
Do you know how expensive those seeds are?
Yeah. They're worth about 2 cents each.
Oh, wow.
They're 1.1 by 3 millimeters.
Okay.
It's a tiny piece of gold. 24 karat gold is best because they're different.
Okay.
But 4 seeds is fine.
Okay. All right. Great. So there are more questions. If during treatment, example of 30% of treatment time on CyberKnife, you have a rigid body error in a distance between the fiducials, can you deviate from standard values of this rigid body within the PTV margin you add? Or does this mean that the patient is somehow not prepared correctly and he's sent for preparation again, meaning bladder failing and rectum failing?
Yeah, the rigid body error and the threshold discussion happens very often because depending really on bladder and rectum prep, the prostate deformed during treatment. So the rigid body, the standard threshold is 2.5 millimeter, but sometimes we go 3.5 millimeters. So ideally, you ask the patient to go to the bathroom or pass gas to have the same fiducial configuration as during simulation, but sometimes it's not possible. So the question,
what do you do then?
Yeah, either you increase the threshold or you can make the
Okay.
decision if one fiducial migrate compared to is in a different position compared to the other two.
Mhm.
You can use the two fiducials and don't correct for rotation and keep a low rigid body error, but you're not correcting for rotation,
Mhm.
compared to using a larger rigid body error and correct for both rotations and translation. In general, the 2 millimeter margins are for both rotation and are valid if you correct for both rotation and translation. If you don't correct for rotation and translation, then a 5
You have to increase the margin.
should be used, and also depends on the imaging frequency. So I guess depends on the margin, on the physician preferences. You can also check if your translation changes, if you disable the fiducial that has a large rigid body, you can check that at least the translation remain constant, and then you can make a decision whether increase the rigid body threshold versus doing translation only with the 2 fiducial that are in the same position. So I think we've done all of them, depending on the physician and on the specific of the patient.
How frequently does it happen at your institution?
Oh, the high rigid body error, quite a bit. I think Dr.
30%? 30%, that's
Probably.
similar?
Yeah, probably, yeah. With some
Okay.
physician,
It's very common.
Yeah.
It's very common.
Very common, yeah.
Yeah.
Another question from Oleg Yermak. Is there technology implemented in some clinics on the Linac that allow for control of daily changes of rectum and bladder volume? And does this technology possibly monitors interfraction prostate motion?
So for monitoring interfraction prostate motion on Linac, there is the gated trigger imaging that is implemented on TrueBeams. So you can set a threshold at a discrete angle during like VMAT. You can take an image, check the position of the fiducial versus the plan fiducial versus where they are at that time, and if they're within a window, you treat. If not, beam hold. So the technology for fiducial gated treatment on Linac, it's available. It's not only CyberKnife. Regarding checking bladder and rectum fluid, I don't think there is anything automatic, but you can definitely, based on the beam, look at the position of the bladder and the rectum and evaluate whether you can go ahead. On the MR Linac and also on the tomotherapy, there is the adaptive planning, in which you can use the anatomy of the patient of the day to recontour, replan, and rederive the treatment. So this adaptive planning is commercially available on MR.
On Ethos also, right?
On the Ethos also.
Yeah. Okay.
Well, some people will give the patient an enema every day.
Mm-hmm.
Some people will put patients on special diets, so the low gas kind of diet, and they control as precisely as possible the bladder filling by limiting or, by having them void beforehand. So you can do other things, but it's not possible to control the bladder and the rectal filling. But those are the best you can do. You can do an enema every day.
What do you do?
I don't do an enema every day unless there's some circumstances that, like if it's a retreatment. Some patients, we re-irradiate people that have had previous radiation.
Oh, I see.
And sometimes if they have, like one guy had brachytherapy, he recurred, and now he's got a lesion in one lobe and we're trying to cover it. And I'm worried about the dose to the rectum. I might just treat one lobe and have him do an enema every day because he's being treated once a week anyway. So I do use sometimes weekly radiation over every other day if I'm concerned about the side effects, complications. Yeah.
Okay. All right. Thank you so much. I would like to open the floor for more questions. If people want to turn on their microphones and cameras and ask a question, please go ahead. Oh, Ruslan.
Yeah, hello.
Hello.
Thank you for great lecture. I have a question about fiducials. Some company offers fiducials like Anchor.
I'm sorry.
They
Say
said
that
that
again.
some company offers fiducials like
Anchors.
Oh,
Uh,
yeah.
anchors, yeah.
Mhm.
And they said that we don't need to wait 1 week between implantation and the CT simulation. Do you have experience with
Yeah,
such
that's
kind
true.
of
You don't have to wait a week.
fiducials?
You know,
We don't.
when we first started doing it, we even had patients that we put it in, like we would start their treatment and then put it in. Our concern is that there are a couple of things that can happen. One is that anytime you, even when you draw blood on a patient, sometimes you get a hematoma. So when you put fiducials in the prostate, sometimes there's a little bit of bleeding and the seed could be the position could be off by a millimeter or two. But for most people, it's okay. But we just arbitrarily say a week later or a couple of days later, but you really don't have to wait. And if you're using an anchor, like some people have these wires that they put in there, you don't have to wait a long time to do it. You can probably do it right away. And we have done it right away. But if it doesn't work, you'll know why. You know, if
Do
there's
you
trauma,
require also MRI together in the same during the same session?
the
MR
same
and
day,
CT same day, yeah.
same day, we try to do it the same day.
Same day. Mhm.
Yeah.
Thank you, Ruslan. Thank you for the question. There's another question from Metros Senchuk. If we treat regional lymph nodes and prostate boost, we have fiducials. We make IGRT match based on fiducials. We should add more margins on lymph nodes because they match to bone anatomy. Oh, that's a good question. If it is so, is this a good strategy? Is this or can this lead to bigger volume radiation in general in comparison with IGRT based
Yeah.
on bone anatomy?
It's a great question. So
Yeah.
first of all, you always want to treat the prostate. I mean, you know, if you're talking about a patient that has positive nodes, like
Right.
on a PET scan, it's a little bit different because there you really want to make sure you hit the nodes. But if you're doing prophylactic irradiation and you don't really know whether the patient has lymph nodes there or not, you think they're at risk, then usually the nodes will live within a couple of centimeters of major vessels. So you can use sort of a class solution to kind of figure out where the nodal, and there are guidelines on where, you know, how you should draw a nodal field. But I still use the fiducials to guide the treatment. And if you're really concerned, you can add a little bit of margin, but you don't want to add a whole lot of margin because you will increase the risk of side effects. The difference is not huge. In our trial 0924, using physician-reported toxicity with whole pelvic radiation, grade 2 is 18%, and with whole pelvis and 14% with prostate only. So 4% difference. Presumably, I mean, I don't know what the patients are going to say, but that's what the physician says. So it's not a huge difference in the side effect profile. But you know, if you mostly want to, when you're doing a pelvic nodal field, you really worry about the rectum and then small bowel. Rarely do you see bowel complications though with whole pelvic radiation, unless it's a post-op patient. So if you have a patient that had a history of abdominal surgery with possible adhesions, that sort of thing, then you got to be careful. But otherwise, most people tolerate it fine.
Actually, a lot of patients are post-op patients in Ukraine, so that's kind of the story there. Thank you so much, both of you, for such a great lecture, excellent lecture. I just want to remind everyone that we have a homework, so I will show you the case in Prono, and thank you to UCSF team for submitting this case. Thank you, Martina, for helping us upload
You're
this.
welcome.
Yeah,
And we're
thank you.
honored.
Yeah. So you
honored.
can practice and you can practice contouring, you can practice planning. I will send the assignment to you. Our next lecture is on SBRT. It will be next week on Tuesday. Thank you to both of the speakers. Thank you for preparing such an amazing lecture.
Thank
Bye,
you.
everyone.
Take
Thank
care.
you. A
Okay.
pleasure.
Bye-bye.
Thanks a lot.